mutation, it is one, but family history can increase or decrease our estimation. Another situation, if we have proband, so patient who is coming to us with, let's say, ovarian cancer, and we make estimation for breast cancer, so of course it will be lower when the proband, so the patient who make consultation is with breast cancer, and the risk can be twice higher or twice lower. Mutation type. So these three mutations are the most common Polish mutations. And look what are big differences for breast cancer estimation, for ovarian cancer estimation with respect to type of mutation. And another thing, this table shows, maybe I have, no, sorry. I wanted to improve something, but I'm able. Something like pointer, yeah. Oh, yeah, okay. Oh, so, okay. Oh, no. This is low. Okay, okay. So here we have women who were born in 30s versus women who were born in 60s. So it is in respect of sisters and mothers, and here we have breast cancer risk. And look, women who were born in 30s, so almost 100 years ago, have lower risk than women who were born in 60s. So it indicates about some environmental factors. And these environmental factors are not, of course, our food, of course, hormones, which are more and more common, but also some kind of civilization. Women who were born in 60s, so let's say I am from this generation, yeah. So we are, in Polish perspective, first generations who were never was hungry, and it was enough food for everybody. The generation who were born in 30s, yes, in childhood, they were maybe food supply was not sufficient, and women were getting first menstruation earlier or later, and 1 year earlier of menstruation. Oh, thank you. 1 year earlier of menstruation is also risk factor, or later and menstruation risk factor for breast cancer. So that's why women who were born in 30s have lower risk, because first menstruation was, let's say, 1 or 2 years earlier, and it is with 1 year, it is 10% higher or lower risk, and other factors. And of course, influence of some other factors is very important. And we have, very especially for oncological patients, and they are coming to us. So we have this question. Women often ask about risk reduction mastectomy despite stage 3 ovarian cancer. In context of treatment with platinum, it is lowers or increases the risk of breast cancer? Because women are already in trouble, they need treatment, and we did such study, and look, it is only 3.9 breast cancer risk in 10 years after treatment of ovarian cancer. So it is about twice lower, even more than for healthy BRCA1 carrier, BRCA2 carrier. And the same result had Evans. Last year, this year it was published that hazard ratio just after ovarian cancer, at least for 5 years, it is the lower risk of breast cancer. So we can delay breast prophylactic mastectomy, especially when a woman is just after treatment and needs to improve immunology. So in penetrance, we have to take into consideration family history, type of mutation, year of birth, previous treatment, and other factors. So who should be tested and how? Today we were talking a lot about this situation, and of course it depends on population. So our Polish experience is like that. Of course, we have 3 breast ovarian cancer, So it is strong family, so it is logic that we suspect that it is mutation. And in 200 cases, it is old study, we found 123 mutations. So very effective way of detecting. But also we are finding mutation in such situation, one ovarian cancer and mutation carrier. It was only question, it is big scale or small scale. We had 3,000 breast cancer patients. We made founder mutation screening and we diagnosed 200 carriers. Between 200 carriers, we asked for family history. 57% said yes, 43% said no. So we say that negative family history, at least in countries like Poland, it is big problem. So genetic family history cannot be factor for selecting patients for testing because we were missing almost half of carriers. So of course, the wider test, the more common it is. Yeah. So the most important factors why it is not full penetrance, not all carriers will develop cancer, and small number of family members. So we are a population with decrease, not like in Pakistan, but it is also changing. Yes, but if we have no family members, so we have no cancer in family history. So who should be tested? Of course, strong families. In Poland, we are very good situation because between these 123, 3 mutations cover 90% of detectable. We were able to increase the sensitivity of this test by adding other recurrent mutations. And now we say that all patients affected with breast cancer or ovarian cancer should be testing for founders. All adults, females with at least one first, second degree relative, so healthy women with breast cancer or ovarian cancer. In population, we are thinking about population screening for all. And now, of course, it is NGS screening more and more. It is less expensive, so we were able to afford it. So who is eligible for testing? All patients diagnosed with breast and ovarian cancer with at least one first and second degree relative affected with breast and ovarian cancer, bilateral breast cancer, and simultaneous multi-centric breast cancer. And all patients diagnosed with breast cancer in age below 45, and all patients diagnosed with triple negative breast cancer. So we make genetic testing in Polish reality. And of course, we are testing patients not to scare them, but to provide them surveillance and prophylactics. And so what we do, if we diagnose woman in the age of 20, so we teach her how to make self-breast examination. And in age of 25, they are starting to come for clinical examination, MRI, mammography, ultrasound in age of 30, ultrasound of female genital tract, and CA125. And MRI is very effective method in young women to detect early breast cancer. Look, there is 100 women with young women with breast cancer, smaller than 1 centimeter, 1.5 centimeter. And with ultrasound and mammography, we can see this cancer only in 40% of them. So it is no wonder that women come. I was last year, 6 months ago, on mammography, and then I felt the lump. Yeah. So it is the story. And we, after many years of using MRI, yeah, so we were able to calculate mortality between women who were carriers, BRCA1, BRCA2 carriers, and were in MRI group, they were attending to MRI, and who were not attending to MRI, because women also have their choice. And of course, women who were in MRI group has smaller tumor, medium 2.3 centimeter. In no MRI group, they knew that they are carriers. They were going only to mammography or ultrasound. Maybe it was too far to MRI. So it was 3.2. But the most important value, it is 20% of them had metastasis to lymph nodes, and here 30%. So it is very important for survival. And when we look at survival curves, mortality, women from MRI group in 20 years of follow-up, almost 95% of them are still alive, and here 85% are alive. It works for each age group between 35 45. It is decreasing annual mortality, and it is and it is also and it is working for BRCA1 altogether, BRCA1 carriers. BRCA2, so we had too small amount of patients because it is not, BRCA2 is not so common in Poland, but odds ratio is 0.35. Also for BRCA2, we believe, so we need some more time to prove it on statistic level. So we think that MRI is effective method to not only to detect early breast cancer, but it has impact on mortality. How it looks with screening for ovarian cancer. So we did the similar study. And if we diagnose ovarian cancer by ultrasound, after 10 years, live 30%. With other methods, especially clinic, 30%. So ultrasound is not effective. What I can defend ultrasound? In group of women who attend to ultrasound, the number who make prophylactic surgery, prophylactic oophorectomy is much higher than between women who don't. So ultrasound is some kind of, let's say, attraction, so-called, but women come to visit doctor, and doctor at the time has the chance to say, please remove your ovaries. You have children and so on. You must live for children, and then women live longer. Screening 30% specific. So, but if we diagnose ovarian cancer, we don't see it before prophylactic oophorectomy, but during oophorectomy, usually 5%, 6% of women are going for prophylactic oophorectomy. They don't know they have cancer, but this cancer is diagnosed during diagnosis. So their chance to survive is 80%. So bilateral oophorectomy increase the life of women. So here there are BRCA1 carriers, no oophorectomy, is 62, and it is 25. So, and between BRCA2 carriers, it is also important difference. So oophorectomy should be done, and it is, I would say, BRCA1, BRCA testing, it is tool to select women who should have this operation. They don't have ovaries, but they have some problems with hormones, of course. They can take or not take hormones. So according to our experience and our data, so women who have no hormonal replacement therapy, it is the risk of breast cancer. They have this risk. Women who take only estrogen, they have very similar risk. And women who have progesterone and estrogen, they have higher risk. So it should be recommended, especially young, healthy women, just to make prophylactic oophorectomy with uterus and to treat them with estrogen hormonal replacement therapy. Of course, we need more data just to prove it on bigger groups. Other screening options. Recently, our Canadian collaborator published paper about platelets, so very inexpensive, and it give any high-risk group with not normal platelets, and maybe between BRCA1, BRCA2 mutation, it is another factor to attract oophorectomy. And of course, there are analyses about pap smears and genomic instability. It is also hope that maybe we will find early ovarian cancer. In prophylactics, so we should inform ladies, especially young in age below 25, 20, that of oral contraceptive is risk factor. About 10%, 1 year of oral contraceptives, 1 year of using is increasing 10% risk of breast cancer, 5 years, 70% higher risk. So it is big problem. Not big problem, but it's big risk factor. Breastfeeding is reducing, yeah, so it should be recommended. So taking together, all our contraceptives are contraindicated, breastfeeding is indicated, late menarche is early menarche is risk factor, late menarche decrease. Annexectomy is recommended, tamoxifen. So I didn't show the study about tamoxifen, but it's decreasing, especially contralateral breast cancer, and prophylactic mastectomy. Of course, it is decreasing factor. Questions who we are working on. What is the role of tubal ligation only? On big scale, it works. Between BRCA1, BRCA2 mutation also, but it's question when to do it. And maybe we should remove ovaries also, but maybe we should do it in age of 35, 40, and ovaries in age of 45. So it is question to be answered. Is hysterectomy necessary? In young women, because risk of endometrial cancer is really low between BRCA1, BRCA2 mutation carriers, so it depends on hormonal replacement therapy. How to safely manage menopause, so it is another, what kind of menopause and so on, barriers of RHT prescribing and uptake, how to manage young cancer patient, rule of screening, and novel prevention options, of course, and can we safely delay surgery. So it is answers to be done. And treatment, very shortly. So some years ago, we did study on new adjuvant treatment of breast cancer patients with BRCA mutation. And if we make platinum and oophorectomy, so the patients have much better chance for long survival. It is black curve. And if it is no platinum, no oophorectomy, so they are in risk. So it is very survival is lower than median for BRCA carriers. Just only oophorectomy and only platinum is still working. Yeah. Of course, olaparib is in game, especially in treatment of ovarian cancer. However, it is very expensive, I think, in each country. And it is coming also for breast cancer treatment, pancreatic BRCA1 carriers treatment, but another factors except of oophorectomy which improve survival, it is contralateral mastectomy. So women who have breast cancer, they should have mastectomy of affected cancer, and contralateral mastectomy is recommended because especially after 10 years, it increases their survival. And the last, should women with BRCA mutation and very small breast cancer and lymph node negative get chemotherapy? In general, indication no. But look at these numbers. So here, per woman, breast cancer about women, node negative, and size. Women who have bigger and smaller tumor up to 1 centimeters and between 1 and 2, so it is similar survival. Here we have women with BRCA1, chemo versus no chemo. Who had chemo, 90% survival, no chemo, 75% survival. So it seems to work. Women who had no chemo, carriers versus no carriers. So nobody had chemo. No carriers, 90% survival, and carriers, 75%. So it works in carriers, in non-carriers, probably not so effective. Maybe there are some subgroup. And the last one, carrier versus not carrier with chemo. Yeah. So if chemo is given, so it is the same result for carrier and not carrier. So the conclusion is also small tumors, women should be offered, and our experience with platinum is really very good. So conclusions, optimal treatment is bilateral mastectomy. Oophorectomy prevents death and ovarian cancer, benefit for extended surgery. chemotherapy for small node negative carriers, yes, chemotherapy for all BRCA2 carriers, chemotherapy, more data for platinum are needed, and combination of platinum and oophorectomy should be indicated. Thank you very much for your being with me.
Thank you, Professor Jacek. It was a very, very good talk. We'll take the questions at the end of the session. So please be seated. So we'll move on to the next talk, which is our virtual talk by Dr. Wing Ki Hu. She's an associate professor of science and engineering, University of Nottingham in Malaysia. And she's going to talk on personalized breast cancer risk assessment for Asians, making sense of genetics. So can I please ask the IT desk to play it? Thank you.
Hi, thank you for having me. I'm an associate professor at the University of Nottingham in Malaysia, and I'm also a visiting scientist at Cancer Research Malaysia. It's a great pleasure to be here today to share with you our work on breast cancer risk assessment in Asian population based on genetic profiling. In terms of breast cancer genetics, there are three regions that we are interested. So if you look at this plot here and focus on the zone between the blue line and the red line, so these are the regions where we have very rare, these variants are very rare in the populations, but once you have it, it confers very high risk of developing breast cancer as compared to this region, which is very common in the population. So a lot of the genetic variants that falls into this region, probably 10 to 30% of the population has it, but individual region confer very low risk of developing breast cancer. So our team primarily focused in the past 10 to 15 years, primarily focused on the top regions here, where such as BRCA1, BRCA2 mutation falls into this region. So very rare in the population, but once you get it, more than 10 times risk of developing breast cancer. And the bottom right regions here, which are genetic variants, are identified through genome-wide association study. So there are about 300 of them thus far that has been shown to be associated with breast cancer risk, but individually, each variant confer no more than 1.2 times risk of developing breast cancer. So individually, that wouldn't be useful for risk prediction, but in the past decades, it has already been shown that if you combine them into one score, which we call the polygenic risk score, it can achieve a useful level of risk stratification. So today's my talk is going to be focused on these two regions. So the two main questions that the team has been asking is for BRCA1 and BRCA2 mutation, is the cancer risk for the Asian BRCA carriers comparable to that of the European carriers? So a lot of the risk management thus far, or the risk management strategy has been recommended based on the risk that's reported for the European population. So we see in a lot of reports that based on the European studies, BRCA1, BRCA2 carriers have up to 80% risk of developing breast cancer. But is that also true for the Asian BRCA carriers? And the second question that we ask is, given that Europeans have already shown that PRS, polygenic risk score, PRS, can achieve a useful level of risk stratification and hence can be used to guide population-based screening, can we also use that in the Asian setting? So early this year, we published the first study to quantify the risk in BRCA carriers from Malaysia and Singapore. So this is a study of 572 families with BRCA1-2 pathogenic variants. And this is what we show. So in a recent study published in 2017, it's a European study, it's reported that BRCA1 carriers has up to 72% lifetime risk of developing breast cancer, and BRCA2 has up to about 69% lifetime risk of developing breast cancer. So this study, our study, shows that So this is a study for, so we used the breast cancer baseline incidence for Malaysian, and then we showed that Chinese, Malay, and Indian women in Malaysia, the lifetime risk of developing breast cancer are all reported to be lower compared to the European population. So this is true for both BRCA1 and BRCA2 carriers. So you can see here the top blue line that for Chinese women in Malaysia who has a BRCA1 mutation, the lifetime risk of breast cancer is 55% compared to 72% in the European population. In the same study, we also compare the lifetime risk of breast cancer of Asian carriers in different countries, so in developed versus developing countries. So the way that we look at these plots is, if you look at the top line, the top blue-green line is the lifetime risk of developing breast cancer for BRCA1 carriers in the US, and the estimated risk is up to about 71%. And the second blue line, the square, is the lifetime risk of developing breast cancer for Chinese in Singapore. And the reported lifetime risk is about 65%. Sorry, the estimated lifetime risk is 65%. So if you compare to the third blue-green line, which is the Chinese in Malaysia, the BRCA carriers of Chinese ancestry in Malaysia have up to 56% lifetime risk of developing breast cancer. So if you look at the orange line, it's the same pattern. The top line, 63% is for Asian carriers in UK, followed by Indians carriers in Singapore and Indian carriers in Malaysia. So what these plots show us is not just the ethnicity matter. So where Chinese has higher lifetime risk of developing breast cancer compared to Indians, and where you live is also matter. So we can see how Asian developed country like Singapore, BRCA carriers in these countries has the lifetime risk similar to that reported in the West, compared to Asian developing countries like Malaysia. Because of the baseline cancer incidence is a lot lower, and hence the lifetime risk of developing breast cancer for carriers in the developing countries is expected to be lower. So that's about the rare variants carrier. So BRCA1 and BRCA2 is very rare in the population. So we're going to shift our attentions to the genetic variants that are a lot more common in the population. So like I mentioned, individually, because they confer very low risk, so individual genetic variants in this blue region here now wouldn't be useful for risk prediction. So what we do is combine them into what we call the polygenic risk score. And this polygenic risk score will form a bell-shaped curve. So you will see that once we combine all the breast cancer risk associated genetic variants, and you come with a plot, it looks like a bell shape like this. And then you can put women into different risk categories. So you will expect those in the yellow zone to have higher breast cancer risk compared to those at the blue zone. So like I mentioned earlier, in the European, they have developed polygenic risk score with 313 genetic variants. And they showed that, so these are the lifetime risks of different percentile of these PRS. And what we showed is people in the top 1% of the PRS distribution actually have lifetime risk more than 30%, right? As compared to women in the bottom 1% of the PRS distribution, the lifetime risk is actually a lot lower. So they asked the questions on, so we asked two questions, right? Can we use the polygenic risk score developed for European population to predict the breast cancer risk in Asian population? And the second question is, can we further improve the predictive accuracy of PRS in the Asian population, either by improving the existing European-based PRS or develop a PRS for the Asian population? So here is just a quick glance on the data that we are using. So we basically, in collaboration with Singapore partner, we have the largest breast cancer genetic study in Southeast Asia. And then we also collaborate with other partner, the Breast Cancer Association Consortium, Asian Breast Cancer Consortium, Biobank Japan, and some prospective cohort to conduct these largest breast cancer genetic studies to develop the polygenic risk score for Asian population. And then, so this is what we did. So the first thing that we did is to evaluate the utility of the European-based PRS in Asian population. So there are a lot of numbers here, but you can just focus on the third column. So basically what we are doing here is in European studies, so the bottom row, in European studies, it has been reported that these PRS, the odds ratio per SD of these PRS, 303 SNP PRS is 1.61. So with the accuracy of 0.63, basically what we do is we replicate. So we use exactly the same set of SNPs and ask whether it's predictive of breast cancer risk in Asian population or not. So the good news is we show that it is predictive, where you can see the 95 confidence interval is above 1, but the predictive accuracy is slightly lower. So compared to what's reported in the European, which is 1.61, if you use the same PRS for the Asian, the predictive power is just about 1.5. So it is predictive, but with lower performance. We then move on to ask whether we can develop a better PRS for Asian population. So the top row, which is what you have seen previously, is using the European-based PRS. So the same set of SNPs and the same set of weights. And then what we see is 1.5. And later on, we add in Asian weight into the European-based PRS. We also include some Asian-specific SNPs into the European-based PRS. So we ended up with a PRS with 333 SNPs, and we can further improve the odds ratio per 5. We're also using a transancestry method and show that if you use 1 million SNPs, and you can further achieve, you can further improve the predictive accuracy of PRS in predicting breast cancer risk in Asian population. So basically we go from 1.55 to 1.62. So you may ask, it seems like it's a very marginal improvement for the odds ratio per SD that I'm showing you. So here is to demonstrate to you why does this matter. So what this plot show you on the x-axis is the odds ratio per SD of each of the PRS that we consider. And the y-axis of this plot show you the proportion of cases you will capture if we offer surveillance to the top 30% of the population with the highest risk as determined by the PRS. So if we look at the European-based PRS, the odds ratio per SD is 1.5. If I now offer enhanced surveillance to women in the top 30% of these European-based PRS, I'll capture 45% of the breast cancer cases in the population. So improving the odds ratio per SD from 1.5 to 1.62 is, and then if we do the same, offer the enhanced surveillance to the top 30%, but now based on the one defined by the genome-wide PRS with 1 million SNP, you can capture a proportion of cases that we can capture now go from the 45% to 49%. So although the percentage is not a huge increase, but if you apply it to the whole population, it does matter. But in terms of practicality, it will be difficult to implement a 1 million SNP PRS, and hence we decided that we can settle in between, i.e. we still based on the European-based PRS, which as some of you may know that have already been implemented or testing in a lot of the European countries. So what we can say is, why don't we just incorporate the Asian rate and add a few more SNPs? So the base is still the same 313 SNP, but just add on a little bit more, and then we can improve the accuracy of these PRS in Asian population. So what does that mean? So we look at these PRS 333. And then we use Singaporean Chinese as an example. So we showed that the lifetime risk of developing breast cancer on average is about 6% for the Singaporean population, Chinese population. So basically, if we treat everyone as the same, the risk is 6%. If we now define the risk based on their genetic risk score, we can now see that Chinese women from Singapore in the top 1% of the PRS distribution has up to 19% lifetime risk of developing breast cancer. If we look at the corresponding 10-year risk, in many Asian countries, we recommend women to go for screening from age 50 and above. But from this plot, you can see that, again, if women falls into the top 1% of the PRS distribution, they will achieve the risk threshold of screening way before the age of 50. So basically, this plot shows us that if we're going to guide screening based on the 10-year absolute risk as defined by the PRS, you can see that top 20% of women in the PRS distribution needs to be screened before the age of 50. And this is a very important finding in our work. So what we showed that we told you that you can, if you don't want to use the improved PRS for the Asian population, you can use the European-based PRS, and it's still predictive of risk for the Asian population, only with slightly lower performance. So same set of SNPs, same set of weight, or same way to calculate the polygenic risk score, but we can see how the bell-shaped curve actually vary across, right? If we now just ignore the distribution of Chinese, Malay, and Indian here and say, okay, we're just going to use the European distribution to do the cutoff, to do group women into different risk group. You can see how, if we take a Chinese as an example, if I map the score to the Chinese PRS score, these women would be grouped in the orange zone. But if we had group the same women with that same score using the European bell-shaped curve, we're going to overestimate the risk of Chinese women. So basically what this plot shows us is population-specific calibration is very important. So you can use the same set of SNPs, same way to calculate the polygenic risk score. But before applying it, you actually need to map to the population-specific distribution for valid risk interpretation. So I just want to say that Asian are actually genetically very, very diverse. So we don't have a lot of South Asian here. So we only have South Asian from Indians from Malaysia and Singapore. So there's no representation of Pakistani population or other South Asian population in our PRS development cohort. But like I mentioned earlier, how you can see the risk distribution for Chinese, Malay, and Indian from Singapore and Malaysia. There's actually 3 different clusters for the Chinese, Malay, and Indian, and hence you see that the 3 bell-shaped curves do not overlay on top of each other. If you generate the same bell-shaped curve for Japanese and Korean, you would expect them to be, again, very different from Chinese, Malay, and Indian. So the key here is we can use the same PRS, but we need to map we need to map the score to the population-specific distribution. So to sum up, is the cancer risk for Asian BRCA carriers comparable to that of European population? So we have been using the values or the risk estimate reported for the Europeans for such a long time. So the findings from our study suggest that not really, because breast cancer risk vary depending on your ethnicity and where you live. So BRCA carriers from a developing Asian countries would have the risk similar to that reported in Europeans, but BRCA carriers from developing Asian countries, so like Malaysia or Pakistan, because our underlying population cancer risk is a lot lower, we'll expect the breast cancer risk associated with BRCA1, BRCA2 mutation also a lot lower compared to that observed in the European population. So for the general population, can we use PRS to stratify breast cancer risk to guide breast cancer screening? So can we offer PRS to women and then reallocate our resources just to target the expensive mammogram screening at those that are at the higher risk? The answer is yes, and we can even use the European-based PRS, but we just need to bear in mind that we need to do the population-specific calibration before using it. And the good news is with very minor modification of European-based PRS, we can improve the predictive accuracy of PRS in the Asian population. So what about the middle zone of the breast cancer genetics curve that I showed you right in the beginning? So there are a lot of other variants. So, well, quite a few other variants apart from BRCA1, 2 have been found to be associated with breast cancer risk in the European study. So these variants are, some of them are rare, some of them are moderate, so not as common as the genetic variants that we use for PRS, but there are very, very limited data in the Asian study. So what are some of the ongoing projects that in the team? So the first thing that we are looking at is, can we come up with one PRS for all Asian ethnic groups? So instead of having, instead of saying that if you want to use the PRS, you have to make sure that you map it to the right distribution, can we make internal adjustments so that this mapping is not necessary? And then can we also quantify the breast cancer risk for other rare or moderate variants carriers like PUB2, ATM? So we are actively recruiting more carriers of these other rare and moderate genes to enable us to quantify the breast cancer risk. So now that we have quantified the breast cancer risk for BRCA1 and BRCA2, can we further stratify the risk? So can we use PRS, lifestyle risk factor, to further stratify the risk for BRCA1 and BRCA2 carriers in Asia? So the last line is something that I haven't had an opportunity to show you, but just want to let you know that the team is also actively looking at mammogram, including mammogram feature for risk prediction. So maybe there'll be room for collaboration. So I'm just going to end with acknowledgement. The project wouldn't have been possible with the mammoth support from collaborators and colleagues, and also our funder. Thank you.
So the next talk is again by Professor Gronwald, and he's going to speak about detection of a new breast cancer gene, example of the ATRIP gene.
Okay, thank you very much again. It is quite long story. So we detected, and we believe it is another gene we could include into our panel. And the story was, we started in 2019. We selected to our series 1018 breast cancer patient with long family history of breast cancer. Mean number affected per family was 3.6, so strong families. First, we excluded, in the easiest way, we excluded carriers with the easiest tool we had. So we applied testing for BRCA1, BRCA2, CHEK2, PALB2, NBN, RECUL, 17 funder mutations. If negative, we decided to make exome sequencing. By the way, in this study, so we could make measurements of frequency of founder mutations in our population, yeah, so in strong families. So about 50% of strong families had mutations. So look how genetic testing, so we think that if there are 3 BRCA1, BRCA2 carriers, so it must be something molecular, yeah? So we are able to prove on molecular level only in 50% of cases, especially at least founder mutations. So maybe other genes, maybe other rare mutations, yes? So easy accessible. They are half of strong families. In 402 carriers had recurrent mutations BRCA1, BRCA2. 92 families had other mutation in other genes. And these were in CHEK2, NBN, PALB2, RECU. Other genes were rare. Yeah. And if we just concentrate on these 4 genes, we will be able to detect with Founder test 80% of all detectable Polish hereditary breast cancer families. So it is on this level quite good test. We selected 510 Polish breast cancer families for whole genome sequencing, and they were negative for this, and 308 controls. And look, we found 3 families with ATRIP, loss of function, and then we extended study on 16,000 consecutive cases from our cohort, yes, from our registry in Poland. And we found 42 carriers versus 2 carriers in 23,000 cases unselected. Then between these 42 carriers, we contacted family members, and we were able to obtain blood sample from another breast cancer patients from 6 families. So we made linkage analysis, and we could prove mutation in 5 of 6 other family members. Yeah. So only in 1 family, another breast cancer patient didn't have mutation. So it was another step to prove that this gene is not only association, but it is something more important. Then we look at UK Biobank, which is accessible. And in UK Biobank, ATRIP loss was seen in 13 of 15,000 breast cancer patients and in 40 of 160,000 controls, giving odds ratio similar to our, we observed 3.3. So in our reality, patient with ATRIP gene, Polish lifetime risk of women, statistic woman is about 9%. So it gives something like 30% lifetime risk. Then we made loss of heterozygosity deficiency in tumor. So we were able to have 10 tumors, and in 8 of 10, we saw loss heterozygosity. So it means that gene in tumor is what also not working. And then we made studies on protein level. It was from construct with empty vector. So it is the first one. Sorry, it is empty vector. Maybe this one. Maybe this one, yeah. Okay. So with empty vector, here it is wild type, and it is with Polish recurrent mutation. So here you see there is no signal from empty vector. It was also no signal from mutation breast cancer tissue, but wild type you have strong signal. So also looking at the function of ATRIP gene, so this protein is involved in cellular responses to DNA reparation stress, yeah, and it is collaborating with ATR. So also this theoretical basics of importance of these genes makes sense. And we did another test. We assessed function of ATRIP gene in this Polish recurrent mutation. So we generated ATRIP knockout cells, and we complemented them with an empty vector, and wild-type ATRIP or mutated ATRIP using AAVS1 system. And look at the signal. So it is empty vector, it is wild type, much stronger signal, and mutation shows also very weak comparable to empty vector signal. Yeah. And another testing. Oh, sorry. And another testing sensitivity of ATRIP deficient and wild type cells to replication stress caused by hydroxyurea. And ATRIP empty vector, ATRIP wild type, and ATRIP mutation, our mutation, yeah? So the curves of empty vector and mutation is similar, and ATRIP wild type is showing different, much stronger signal. And then we controlled expression by immunochemochemistry in breast cancers. So we had 10 women with breast cancer and ATRIP mutation. So this, which was detected frequently in Poland, versus an affected woman with germline ATRIP mutation as a controls. And here you have signals for, it is strong accumulation of normal ATRIP gene, ATRIP signal from ATRIP gene in breast cancer cells, and of here it is moderate ATRIP accumulation, and other slides show the same. And the last one, functional test, ATRIP expression by immunochemistry in breast cancer with or without ATRIP mutation. So we the stain score was calculated using German semi-quantitative scoring system from 0 to 12, considering the staining intensity and area extent. And the mean ATRIP protein accumulation was lower in breast cancer with ATRIP, this recurrent mutation, than with breast cancer without. And it was statistically significant. So based on our observation, we conclude that ATRIP is a new breast cancer susceptibility gene candidate. We already included it into a web panel of founder mutations. So we test all consecutive patients for this. So soon I hope we will have more data. And we were able to publish it as a first in the American Journal of Human Genetics. And 3 months later, another group confirmed our observations. Yes, they published in Nature Genetics, but a bit later. Yeah, so they look at, they were in journal almost 1 year, June 17, 22. So you have, if you want to be fast, so maybe you have to think in journal which proceeds faster. Thank you very much for attendance.
Thank you, Professor Jacek. You finished on time. That's great. And we'll take the questions at the end of the session. So I would like to invite our next speaker. This is the last talk of the session. And this is by Wing Ki-hu, who is an associate professor of science and engineering at University of Nottingham in Malaysia. And the title of her talk is Predicting the Likelihood of Carrying a BRCA1 or BRCA2 mutation in Asian breast cancer patients. Please, IT stand, play the presentation. Thank you.
For the second topic of my talk, I was asked to talk about the BRCA prediction tool that we have built for the Asian population. That's called ERICA, so Asian Genetic Risk Calculator. So before I start, I just want to acknowledge that this work is led by the postdoctoral scientist, Dr. Ang Boon Hong in our team. So she's the principal developer of ERICA. So a little bit of a background. So why do we do genetic counseling and genetic testing? So for two purposes, for the healthy individuals, the main purpose for genetic counseling and genetic testing is really to identify whether the person has gene mutation carriers, and hence we can offer enhanced surveillance to make sure that we detect the cancer when we detect the cancer at an early stage, or we can offer some form of prevention. But when it comes to breast cancer patients, so the purpose of genetic counseling and testing is more on the therapy selection. So there are different guidelines out there to guide clinicians on who to refer or which breast cancer patient to refer for genetic testing. But at least what we observe in Malaysia or in a lot of the developing countries, because the guideline is actually developed based on the European populations, a lot of time we find that the criteria for the genetic testing guideline is actually confusing. And this actually led to poor adherence to clinical guidelines and also low referral rates among the clinicians. While the challenge with the patient is criteria alone may not be convincing, and hence we have observed that the uptake of genetic counseling and genetic testing has actually been low in the Malaysia setting. So are there any prediction tools that can be used to predict how likely a breast cancer patient is a BRCA mutation carrier? So the answer is yes, but a lot of these prediction tools have actually been developed for the European or women, or some developed for the East Asian population, but based on the high risk cohort, so the high risk group. So I'm going to talk a bit more about that later. But there's a difference between European and Asian. So as we all know, so in terms of breast cancer, age of breast cancer diagnosis, Asians are diagnosed at a younger age. So our average age of breast cancer diagnosis is around 50 years old, compared to those in the European population. So the clinical guideline for testing, of course, age is one of the criteria. If we rely on that, we're going to over-screening the cancer patient in Malaysia. And the ratio of BRCA1 versus BRCA2 parents are also different. So what you're seeing on the left here are some of the data from the West, while what you're seeing on the right here are some of the data for Asian. So you can see that the ratio of BRCA1 to BRCA2 prevalence are actually different. So we do observe having more BRCA2 carriers, higher proportion of BRCA2 carriers compared to BRCA1 carriers in Asian compared to the West. So if we just directly apply what has been developed for the European to the Asian, we will expect to underestimate BRCA carriers in Asia. And hence that leads to the objective of our study is to develop and validate a population-specific prediction model that we call it Asian Genetic Risk Calculator, ERICA. And the main purpose is to use this to predict what's the likelihood of an Asian breast cancer patient being a BRCA mutation carrier. So in terms of study population, so this is again a Malaysia-Singapore collaboration. So we are using 8,000 breast cancer patients recruited from 2 hospitals in Malaysia and 6 hospitals in Singapore, of which we have 323 BRCA1 and BRCA2 mutation carriers. So what we did is we split them into 70% training set and 30% validation set. And it included factors so we actually test a range of factors that may be associated with the likelihood of being a BRCA carrier among the breast cancer patient. And what we include are demographic, like what you're seeing here, tumor characteristic and family history of breast and ovarian cancer. So what you're seeing in the red are the corresponding odds ratio. And what we can see is being younger age of diagnosis, Indians, bilateral breast cancer, ER negative, HER2 negative, having higher grades, having first degree family history of breast or ovarian cancer are all associated with higher likelihood of being a BRCA carriers. So we included all these factors into our prediction too. So what does the performance look like? So we built the two to ask well, basically we asked the two to predict whether someone is a breast cancer patient is a BRCA carrier or non-BRCA carrier. Is the patient a BRCA1 carrier or non-BRCA1 carriers, BRCA2 carriers or non-BRCA2 carriers? That's why you're seeing three performance curve here. So this is an AUC curve of if you get a 0.5, it means that it's just flipping a coin. Things are by chance, so it's no good at all. So if you get a 1, it means that the model has a perfect discrimination. So what we are seeing here is Erica actually discriminate well between BRCA and non-BRCA carriers, or BRCA1 or non-BRCA1 carrier, BRCA2 or non-BRCA2 carriers for the validation cohorts that we use for testing. So what about calibration? So again, so what you're seeing here on the x-axis is the expected probability of being a BRCA carriers, and the y-axis is the observed probability of being a BRCA carriers. So what you would like is to have all the dots actually align at the diagonal lines, and the bar of the top there, the bar with surrounding the dot is actually the corresponding confidence interval. So what we are seeing here is actually Erica accurately identified carriers at different levels of probability. So as of now, what we see is in our validation cohort, the Erica2 actually discriminate well and also calibrate well. We also compare these two with some of the other two out there. So what are out there? There's Budisia, which is a European based model. It was built based on using the general population like Erica. So we didn't select cases based on high family history. Sorry, it means that it's an unselected cohort. So Erica is built based on breast cancer hospital-based breast cancer cohort, unselected for their risk of cancer. So same, Budisia is also based on a population-based cohort. So there's another two. PAN2 is also a North American or European-based, and COCAL, which is an Asian-based model, but both PAN2 and COCAL were developed based on high-risk cohort. And of course, the model, it will be slightly different. So Budisia used polygenate, Erica, PAN2, and COCAL used the logistic regression model. So if we compare the components that are included in each of these models, so there are some overlapping. For example, age bilateral were included in all. But for Erica, so we include ethnicity and grade, which both of these were not considered by all the other three models. So what does that look like? So the top row here show you the performance of Erica, the AUC that we have shown you earlier. And then the bottom three rows are the corresponding AUC for each of these model. So what we can see here is you can tell that Erica actually discriminate better than existing model, particularly for BRCA2. So if you look at BRCA1 column, Erica, the AUC is about 0.85 compared to the others model, between 0.82 to 0.84. But for BRCA2, for the other model, the performance is from 0.63 to 69, but Erica performed a lot better at an AUC of 0.75. What about the proportion of BRCA carriers detected? So again, we use exactly the same cohort here, but different methods for the evaluation. So what we see here is if we use Erica, we will refer 71% of the patient for testing, while we can Oh, sorry, this is not about referring, this is about the proportion of BRCA carriers that's detected. So, okay, apologies. So for the top row, what you're seeing here is if you use ERICA, you can detect 71% of the overall BRCA carriers, 83% of the BRCA1 carriers, or if you look at BRCA2, it's a 66%. Again, we can see that the proportion of BRCA1 carriers that we can detect is actually similar across the model, but ERICA can detect more BRCA2 carriers than the existing models. So this is the one about eligibility. So if we use ERICA, we can see that 31% of the patients will be eligible for genetic testing, of which we can capture 71% of the BRCA carriers. So if you compare to the clinical guideline like NCCN or MCG. So what you're seeing is NCCN referring 37% of the patient actually will fulfill the criteria, are you eligible for genetic testing based on the NCCN guideline, and we can capture 72% of the BRCA carriers. So in a ratio that is really saying that you will find 1 carriers in 11 that you refer for genetic testing for the ERICA, but you will find 1 carriers in 13 of the patient that you refer for genetic testing based on the NCCN guidelines. So what we can see here is ERICA actually refer fewer patients for genetic testing than the clinical guideline. So what are the summary key takes away is we can see that the population-specific prediction model or tool can identify more BRCA carriers than the existing model built on other population. And the reason or the factors that could contribute to this better performance could be, like at the beginning, I showed you how the mutation prevalence are different, where we have higher BRCA2 mutation than BRCA1 mutation compared to the West. So maybe the reason is because we have taken into account the mutation prevalence that's population specific, and also inclusion of grade, which was not used by other models. So what we can see is, like in the previous slide, how ERICA actually refer fewer patients for genetic testing, but identifying more carriers, suggests that ERICA could save costs in healthcare system. So just to share with you that ERICA is now in a trial. So basically what we do is we want to ask the questions on will adoption of ERICA in clinical setting helps to increase the uptake of genetic counseling and testing for patients. And of course, but also whether ERICA is a user-friendly tool for clinician or not. So the trial is currently still ongoing. Hopefully I can come back here to share with you a little bit more about the result of the trial. But basically now we have integrated ERICA into a web interface that's user-friendly. So again, call for collaboration if you're interested. So can ERICA be used in other Asian populations? So we actually collaborate with Dr. Usman to evaluate the performance of ERICA in the Pakistani population. And we're also working together with the Thailand group to do the same. So if you're interested in evaluation ERICA in your population, please do reach out. And here is just to show you, this is the publication about ERICA. So again, acknowledgement again. Thank you to the team as well as our funder.
Okay, so with this talk, we are open for the question and answer session. Anyone who is willing to ask the question? Any question from the audience? No?
Okay, so actually I have a question from Professor Jacek. So in terms of genetic counseling that you offer to all these right. So in terms of the genetic counseling that you offer to these participants in the study, do you offer storage of eggs before going for oophorectomy?
It's working, yeah? Okay. So it is possible. Yeah, and in general, the practice is that women who decide for prophylactic oophorectomy and they are healthy, so they decide to do it just after situation when they have children when they plant. So it is extremely rare situation, especially in women a bit older. The story is when women get cancer and they must have chemotherapy, and including chemotherapy, so in plan. So I think a week ago I had a patient. So she was 30, BRCA1 carrier, breast cancer patient, and she was thinking about taking ovarian cells for storage, yes, and so on. So it is option, yeah, it is option.
So do you think it is advisable, because you know already that the genetic material has been compromised in terms of genetic diversity?
So in this particular case, so I said that it is not the best idea because the cancer was very early.
Yeah.
And with treatment, I would say the chance for pregnancy after treatment was calculating, our reality was higher than putting this lady after that in vitro procedure, even after 5 years, because she was 30. But I would say it is option, but I would say for women who, let's say, had breast cancer in age of 35 and then try to get pregnant in age of 40, yes, let's say 38, 37, if it was early onset. I think I have too little data to say, yes, do it.
Yeah.
Because then she needs also some strong hormone treatment and so on. So if it is safe for her, so we don't have enough data about it.
Okay.
But for healthy women, I would say just wait. It's question about, let's say, 40 years old woman. She just want to have children, and she's still healthy. And her sister and another sister and so had ovarian cancer. So I'm just suggesting, just try now, because these in vitro procedures are not so effective. Yeah, yeah.
Okay, thank
Okay,
you.
so I have two questions from your second talk. First, that you show some images of Western blot and the immunofluorescent cells.
Yeah.
So are they both from the same cell line? Because in the Western blot, we had almost no signal for the ATRIP mutated gene, but in the IF cell, there was quite strong signal in the nucleus. So how will you?
But it was comparable, the signal from mutation and
In the Western blot, yeah.
So in Western, so this first one, yeah.
Yeah, yeah.
So it was no signal from empty
Yeah.
vector, and
No,
was signal.
not the empty, the mutated one, mutated gene.
So they mutated, it was mutated gene, so it was no signal.
Okay.
I think so.
And did you check any cells, because it's involved in the cell cycle checkpoints? So did you do any proliferation assays or to see if, okay.
It was not checked. Yeah, yeah. Thank you.
So we have an
So,
online
thank
question.
you for the
There's one more
lovely
question.
talk.
Yeah.
So wonderful presentation regarding BRCA. So I referred two of my patients who were BRCA positive to a surgeon last week, and he asked me a question that should we do hysterectomy as well, as you mentioned in your talk as well. So, some of these patients require tamoxifen, which is also a risk, which also has some risk of the endometrial cancer. So do you think it should be offered to the patients or?
So women BRCA1 or BRCA2 carriers who are on tamoxifen, so we just make amputation of a corpse of uterus in context of tamoxifen. Yeah. So and we just leave the cervix.
So it's definitely quite low risk, but even then there is some risk. So do you think should we ask our surgeon to do the hysterectomy as well?
Oh, it
At the
depends
time
on,
of oophorectomy?
it depends. So what we do, yeah. So it depends on the state of cervix. If cervix is in good condition, so we just make amputation and adnexa. If woman is healthy, okay, so there are different. If woman is healthy and is thinking, I will do prophylactic mastectomy, so we just do just ovaries and fallopian tubes. If women say, I don't want to make prophylactic healthy, I don't want to make prophylactic mastectomy, so we do amputation of uteral corpse, hysterectomy if state of she's, for example, virus positive, HPV virus positive, or let's say cervix looks not good.
Okay.
So hysterectomy,
Okay.
yeah. But if it is okay, so we just make it this easier operation, and it is, all, better ligaments come into cervix. So we just leave cervix, and then we put her into surveillance of cytology. Yeah. If woman is affected with breast cancer and is triple negative, so we just do, and she will not get any tamoxifen, whatever. So we just do fallopian tubes and adnexa. We remove adnexa. If she is taking tamoxifen, so we make an amputation.
Correct.
So
Thank
it
you.
is.
Yeah, I just wanted to ask, what are the allele frequencies in the control population for ATRP and BRCA1 and 2?
So, in Poland, yes. So I know the data about, so BRCA1 frequency in population. So it is 1 in 350. So it's quite high. It's high. For ATRP, so it was one slide. So it is 1 in I think 11,000. Yeah. So it is quite low. Yeah.
Thank you. We have Dr. Hu with us online. Thank you so much, Dr. Hu. Your talks were very, very informative and really good. I have a question from you that all these population-specific scoring models, do you consider missing data in them? And what is the importance of missing data in calculating all these, prediction scores?
Hi, can you hear me clearly?
Yes.
I suppose that you're asking about the ERICA model that we are building. So yes, we do consider missing data in the model development stage. We actually use advanced imputation methods to impute data that are missing. In terms of when we integrate the ERICA tool into the web base, we basically ask for all the information that we included in the model, but of course, some of this information may be missing. So there is an automated imputation algorithm, I should say, behind the web tool. So if the data is missing, then we will impute it. So your second question is, how is that going to impact things? Of course, so this is very hard to say. So it depends on what elements are missing. So if you have all the variables available, that's where you best predict, right? So the prediction will be probably the most accurate if you have all the variables that included. But if some of the variables are missing, what we do is we base on the best that we could impute and then come up with a score. So would the score be as good as the one where you have all the data available? Of course not.
Yes, definitely. Okay, thank you. We have another question.
Another question from our online participants. It says that in which base did you choose Bodica and PEN1 as European models in your study for the comparison?
So if I understand these questions, it probably asks why do we choose Boudicca and PEN2 as a comparison model?
I wanted to ask about the mutation that you used for the comparison, I guess, from the European models. I think this is what the mean.
So what we do is we compare so you can see we look at overall BRCA. We also look at BRCA1 and BRCA2 in terms of the accuracy of the prediction. So why do we choose Boudicca and PEN2, the European-based model? The whole purpose there is to show that if you have a population-specific model, it actually has a better discrimination ability compared to, or better accuracy compared to using a European-based model directly to the Asian population because of the sum of the differences between Europeans and Asian. For example, I mentioned earlier the proportion of BRCA1 to BRCA2 is actually different in Asian compared to Europeans. So the whole point there is to say, now that we built two, and why do we want to build that too? Because if you compare to what European has, you use it directly in the Asian, it doesn't do as well compared to building one using the Asian.
Okay, thank you. Actually, we have another question for you, Dr. Hu. So the question is that do the 313 SNPs PRS also included SNPs in high, moderate, and low penetrative genes already proven associated with breast cancer?
High moderate penetrance gene is where we say like the BRCA mutation. So not like no. So the 313 SNPs are actually genetic variants that are very common in the population, but they are very low penetrance.
Right. Okay. Okay. Thank you very much. So any more questions from the audience here? Yes, we have another. We can take this last question.
Assalamu alaikum. I have a question from Dr. Jasik that if the patient has BRCA2 or BRCA1 mutation, are there any studies going on that if the patient doesn't want any oophorectomy prophylactically, then are there ovarian sampling to detect the occult metastasis, occult malignancy in the ovaries?
Could you repeat? I didn't understand.
Yes.
correctly.
If the patient has BRCA mutation, either BRCA1 or 2, and patient is obviously young and she doesn't want bilateral oophorectomy, is there any study going on or do we have any data on bilateral ovarian sampling to detect the cancer in the ovaries?
So
Occult cancer.
So she doesn't want to make prophylactic surgery.
Yes.
And what
Like
is
can we
other
not
option?
can we not do any ovarian sampling to detect the occult
So you
malignancy?
the ovarian sampling, you mean laparoscopy and something like that?
Yes.
In this, so so there are studies. Yes, so there were some. So as a routine, no. Yes, we are doing, for example, CA125 measurement, and if it is higher, so we make laparoscopy.
Right.
Now there are studies, already published on platelets level. So simple story. And it is indicator. It is not diagnosing, but it putting patients in high risk group. And also, even we applied for grant. There are some sequencing analysis from pap smear from cervix. And for example, some mismatch repair abnormalities and so on, and some genes. And we believe that from cervix, there are some singular cells or whatever markers where we will be able to detect pre-malignant state, but as a routine, nobody is able nowadays, according to my knowledge, to detect early ovarian cancer.
Okay.
Yes.
So the question arises that if the CA125 levels are similar in these BRCA carriers or a bit lower levels are detected for oophorectomy.
I would say it is just if it is BRCA carrier, and if the woman has, the children and she's in age of over 35, so I just recommend.
Oh.
If woman doesn't want to make surgery and CA125 is, so just I recommend her do laparoscopy. If everything is okay, just forget about it, because it is not specific carrier. I have lady and she is, in national team in handball, and she had all the time 120.
Okay.
And there are some women with endometriosis also. So we just give a time to have children. Yeah.
Okay.
But if it is rising, so just make a laparoscopy and just exclude cancer.
Okay, thank you so much, sir.
Thank you.
Thank you. With this, I conclude this cancer research session. I thank all our speakers online and participants. Thank you so much. Allah Hafiz.